So we're going to talk about some dysfunctional labor patterns now. Dysfunctional labor is defined as a long, difficult, or abnormal labor. And there are some contraction patterns that we look at, okay? First, abnormal uterine activity. If the uterus is not acting in a coordinated way, then that's going to impede delivery. Hypertonic is most often seen in the latent phase, and that's when the patient is having painful, frequent contractions, but they're not actually dilating or effacing the cervix. Usually, this will eventually turn into active, effective labor, but by that time, the patient may be exhausted. They may have contractions that are painful enough to prevent them from resting for 12 to 24 hours, sometimes even longer, but they're still not changing. The risk of this are exhaustion and frustration. Frequently, these patients are treated with therapeutic rest. We have them take a warm bath, maybe an analgesic to slow those contractions down or to decrease the pain of them. They can get some rest, and a lot of times that patient will then wake up in active labor. Hypotonic is something that happens in the active phase. So hypertonic, they're having too many contractions and aren't doing anything. Usually that's the latent phase. They're not actually in active labor yet. Hypotonic happens when in the active phase of labor, the contractions get weak and ineffective or even stop. This can also cause exhaustion, frustration, and because active labor's progressing, they've had some dilation, they may have had rupture of membranes, the contractions piddle out, now we're maybe increasing the risk for infection. Management, the major thing the provider is going to do is make sure that that fetus is not in a position that doesn't allow them to descend or not too large to descend. Other than that, we monitor fetal status, monitor uterine activity. They need an intrauterine pressure catheter, ideally, to monitor uterine activity so that we can see what the contractions are really doing. If the fetus doesn't appear to be too large or in the wrong position to move down, then augmentation would be tried. So they're probably going to get Pitocin to get their contractions started back. Arrest of labor. This is the patient is in active labor and they stop progressing. Usually this is going to be, again, because of a presentation or size issue. The baby's not fitting through the pelvis in the way that it's trying to come through. We're going to evaluate uterine activity. Are they having enough contractions? The provider is going to evaluate the position, presentation, station of the fetus, and estimated size. And then if all of those things indicate the fetus should fit through and isn't in a weird presentation, then they would augment labor. But you don't want augmented labor on a fetus that can't fit. So they've got to rule those things out first. Inadequate secondary powers is they get fully dilated and then they stall out. Either they don't have enough contractions or they have an inadequate bearing down reflex. Sometimes this is related to anesthesia or analgesia, so their epidural or their pain meds. More likely epidural or spinal is going to cause this than IV pain meds. So if that's the case, letting those wear off a little bit may help. Sometimes it's because the fetus cannot move down. Again, that can be because of malposition, or it can be because the fetus is too large, cephalopelvic disproportion. Sometimes we see this and the fetus is trying to move down and keeps kind of bouncing back up because the cord is just too short to allow them to move down. Management, if they think it may be due to the anesthesia, they're going to decrease that. We may try changing the maternal position to allow the fetus to be able to change position and move down. We may just give them some time without trying to push, just to see if the baby moves down, just laboring down. If there's a malposition that can be corrected, the provider may correct that. Sometimes I've seen if they've moved down some and maybe the head is stuck transverse, or OP, then the provider can try to help rotate that. If they can't get them descended, if they can't get the baby to move down, they do a C-section. If they're crowning or near crowning, they can do instrumental delivery. Precipitous labor is the opposite. Those are all, we can't get the baby to come out. Precipitous labor is a labor lasting less than 3 hours. And a lot of people now are saying, well, that sounds wonderful, except you're doing all the same amount of cervical change and pushing, but in less than 3 hours. So who's more likely to have this happen? They're having too many contractions, uterine tachysystole, too many contractions, too close together, too strong, okay? Too long, too strong, too close together, or too close together, yes. Induction of labor is more likely to cause tachysystole, so a patient being induced is more likely to have this precipitous labor. If they've had several children before, if they have a history of rapid labors, a patient with a large pelvic, internal pelvic diameter, doesn't have anything to do with width of the hips really, but the internal pelvic diameter is large and the baby is comparatively small in an optimal position, that baby can just shoot right out sometimes. Recent use of medications that cause, or not medications, but drugs that can cause uterine contraction like cocaine or meth. Okay. The risk, one risk is that the baby delivers so quickly the provider can't be there. But if that uterus is contracting that much and trying to just shove the baby out, we can have uterine rupture. The cervix can be lacerated, which can lead to incompetent cervix and future pregnancies. The vagina, the vaginal canal can be lacerated. The perineum can be lacerated because that rapid delivery doesn't allow enough time to stretch. They can have an amniotic fluid embolus because they can have an abruption first. Let's go back to that. So during labor, if the contractions are too hard, too strong, too many, they can actually disrupt the placental implantation and cause an abruption. So if the placenta abrupts, if the placenta peels off the wall of the uterus and there is, so we've got exposed vessels, exposed maternal vessels, if there's still amniotic fluid in the uterus, then that can get into the mother's bloodstream and cause something called amniotic fluid embolus. And we're going to talk later about the consequences of that. But amniotic fluid embolus is more likely in this really fast, sudden, get the baby out right now labor. They're more at risk for postpartum hemorrhage because the uterus does all this work, gets the baby out in 3 hours or less and says, nope, I'm done now, and doesn't want to contract to stop the bleeding. We can have fetal hypoxia because the contractions are too much for the fetus to be able to oxygenate in between. Shoulder dystocia because the head gets delivered too quickly and doesn't allow for appropriate rotation. Then the shoulders can get stuck on the pelvis. Intracranial trauma, if the head delivers really quickly, the head kind of squishes as it goes through the birth canal. The bones overlap as the head moves down through the pelvis. And then when the head's delivered, it can expand a little bit. If the head's delivered slowly, that expansion is not sudden. But if the head just pops out, then we can go from this overlapped skull bones to popping back out, really rapid expansion, which can actually tear some blood vessels and cause intracranial bleeding. Okay. Also, even if there are no complications of this, this is an intense traumatic experience. These patients will tell you it felt like they were trapped. They were tied to the front of a speeding train. They cannot get on top of this labor. So it's very overwhelming and even traumatizing. And patients who've had this experience sometimes have some PTSD. Management, we want to provide a lot of one-on-one emotional support for this patient. As the nurse, realistically, it's hard to do that because we've also got to hurry up and get everything ready for delivery. So if they have someone who can help them stay focused and get through this labor, it's really helpful. If they labor in a side-lying position, that maximizes blood return, so they get better oxygenation to the fetus, but also it can kind of slow things down a little bit. If they're getting any medications that cause contractions, if they start progressing like this, we want to stop them because we don't want to add any more contractions to that. If they're having one contraction that lasts a long time and just won't relax, a medication can be given like terbutaline to stop that tetanic contraction and allow some perfusion. Women who have a history of very rapid labors may actually have a scheduled induction, where they're going to be very cautious with the method of that induction, but they may have a scheduled induction in order to prevent a surprise out of hospital birth. So those are all things that have to do with uterine activity that can cause a dysfunctional labor. Now let's talk about maternal structures. If the mother's pelvis is contracted or not fully developed, so if we have a very young mother, early teens, or if we have a pelvis that's contracted because of a previous injury or because of rickets, that can obstruct birth. So the patient may not be able to give birth through a pelvis that either cannot expand or is malformed or is not fully mature. We also can have obstruction by soft tissue. That means there's soft tissues that are in the way. Placenta previa is one. We already know, and if we do get the placenta out of the way before the baby's out, then the baby doesn't have any method of oxygenation. So placenta previa. The patient can also have fibroids in the uterus that, if depending on size and placement, can impact the fetus being able to move down and deliver. A full bladder or rectum, this is one of the easiest ones to remedy. They used to give enemas to everybody in every labor. We don't do that routinely anymore. There's not really good evidence for it, and it tends to cause actually liquid stool to be expressed during delivery instead of solid. But if someone's constipated, that full rectum can actually impede the fetus moving down. And so in that case, dealing with the constipation can be helpful. And if we let the bladder get full and stay full, it can impede the fetus being able to move down. Cervical edema, if they're pushing against a cervix that's not fully dilated, they can cause it to swell and slow things down. And then there are some STIs that can cause obstruction, like sometimes someone will have a large cluster of genital warts that may cause an obstruction. There are some fetal causes, so some things with the fetus that cause abnormal labor patterns or obstructed labor. If a fetus has an anomaly is going to be some sort of structural abnormality. Something about the structure is wrong. Okay. Some anomalies can actually impede delivery. So there are some anomalies, for example, to the skull that might make it more difficult for the skull to change shape to allow for delivery. So fetal anomalies that don't allow for delivery. Cephalopelvic disproportion means the head is too big to fit through the pelvis. That's a retrospective diagnosis. And it's also, there's a lot of disagreement about what CPD actually is. There are some cases that it's really clear that head is not fitting through that pelvis. But it can also be due to position. It can be that head will fit through that pelvis in the perfect position, but it's not in the perfect position and we can't get it there. Sometimes it's also because it may be diagnosed when that patient just really wasn't in active labor yet. So CPD is a real thing, but it is sometimes kind of used as a trash can for every baby that doesn't come out vaginally. Position or presentation of the fetus can affect how labor progresses. Transverse babies cannot come out. Breech babies, the labor a lot of times will be slower because the bottom or the feet don't put pressure on the cervix the same way the head does to dilate. And then, of course, we can have a partial delivery and the aftercoming head gets stuck. Another potential cause of dysfunctional labor is maternal position or contributing factor. So sometimes if we can get the mom into a different position, it changes the way the labor is progressing. And then there are psychological factors. Stress and anxiety can actually slow the progress of labor and make it more painful. Okay, so next section, we're going to talk about meconium in the amniotic fluid.